Mr. Chairman and ladies and gentlemen, it's a great pleasure having me in your session, being supposed to provide the introductory lecture. Actually, I will focus and present you the clinical benefits of proper nutritional therapy for the patient and its impact on the healthcare system. And by doing so, I will focus on elderly patients because they are really threatened by acquiring malnutrition. So this is the agenda I'm going to work through together with you. And I will start with prevalence of malnutrition and will acquaint you with some figures of Europe, of Asia, and of South Korea. So the population of Europe is accounting to 750 million. Around 30 million are presenting with malnutrition, and around 160 million are elderly patients or elderly people, so to say, above 65 years. And half of these elderly, around 80 million, are at nutritional risk in Europe. So this is a big number. What is the situation in Asia? Asia population is 4.7 billion. This is huge and representing 60% of the world population. And by 2050, it will be 1.3 billion elderly people, which is more than double of what was the number in 2015. And even more, 1/3 of the population is predicted to be over 60 years old in 2050, and 1/5 of all these who are over 60 will be over 80 years old. So Europe and Asia are going to have a lot in common, although it may hit Asia even harder because of the higher population figures. So what's the prevalence of aging in South Korea? The population development in South Korea is steadily increasing. At the same time, however, total fertility rate is decreasing. And as of 2021, South Korea is the country with the world's lowest total fertility rate. And by looking on the demographic pyramid, you see this change in aging. If you compare the figures of 1955 with those of 2050, you clearly see the aging of this society. And now you can ask, is this of relevance? And I'm saying you, yes, it is. Aging is associated with malnutrition. And the underlying reasons, as well as the causative pathophysiology, is the same for Koreans, for Europeans, and Americans. So what is the European prevalence of malnutrition in older people? Malnutrition is significantly more common in older people. We know this from our data in Europe. And an aging population will only exacerbate the problem in years to come, even in Europe. And at the situation now, about 1 in 3 older people in the hospital are at risk of having malnutrition. More than 1 in 3 people in home cares are at risk of being malnourished. And around 1 in 3 older people living independently at home are at risk of being malnourished in Europe. And we estimate that 93% of malnourished people are living in the community. So this is the main problem here. Okay, what is the Asian prevalence of malnutrition in community dwelling older people? So the prevalence is currently reported being 16 to 73% of people being at risk of malnutrition in Asia. So this varies a lot, but there are other figures telling us about patients who are being malnourished, and this number is reported as high as 22%. So around 1 in 4 older people are malnourished in Asia. And this is repeatedly demonstrated in various Asian populations. You see the references below. And the figures are quite comparable to the prevalence in Europe. So what can be concluded on the prevalence of malnutrition? Studies across the world show that malnutrition is common in patients in hospitals, in care homes, even in patients who are living at home. And malnutrition is particularly common in older people. And of note, for example, 30% of nursing home residents eat half of their lunch, often failing to meet their nutritional needs. And with an increasingly aging Asian population, malnutrition is a growing problem. So what are these causes of malnutrition? And before we go into details, I will, in a more general perspective, acquaint you with some thoughts which are important. There are several causes leading to malnutrition. There is, on one hand, starvation. On the other hand, there is inflammation as a leading cause for malnutrition. And this is differently impacting on the reversibility of nutrition therapy and the effectivity of nutrition therapy to treat malnutrition. So if you look on this simple graph, it appears very easy. You have a lower intake, probably higher requirements. You have maybe malnutrition in the patient, malabsorption, and this is causing malnutrition. And all of a sudden, the patient winds up with decreased muscle mass and decreased starvation. But the reasons that this malnutrition appears is quite different in different patients. And the best you can have is simple starvation. If simple starvation happens, this is fully reversible by nutrition therapy. And what causes simple starvation? This is disease-related malnutrition without inflammation. We also call that non-cachectic disease-related malnutrition. For example, dysphagia is a cause of disease-related malnutrition without inflammation. So this is easily treatable and patients getting better. And there are other causes of starvation, which is undernutrition without even a disease. We call this non-disease related malnutrition. And this is hunger due to social, psychological, or economic reasons. Also, this is nicely treatable. And these are the low-hanging fruits. I think this needs to be addressed firsthand. So these things are nicely summarized by a very recent publication coming from Asia. It's the Asia-Pacific Clinical Practice Guidelines for Management of Frailty, who are depicting these reversible causes of weight loss in the right panel. And you all see these good old friends. Again, oral problems, swallowing problems, and you name it. And they are recommending that older adults with frailty and unintentional weight loss should be screened for reversible causes and considered for nutritional supplementation. And this is this recommendation number 5 I'm referring to, published in this publication. And they explicitly say these patients should get protein and caloric support or food fortification. But at the same time, they are also referring to sarcopenia. And they say this is a growing public health problem in healthy community dwelling older adults in Asia as well. And sarcopenia is not that nicely reversible as it is starvation. And I will show you this. So this slide you already know. These are the low-hanging fruits you can approach with simply providing oral nutritional supplements or something. But if it comes to sarcopenia, we are dealing with a separate disease entity. Yeah, there are multiple causes of sarcopenia, which I'm not supposed to go into detail at that point. But you need to be aware that these reasons causing sarcopenia during aging are causing irreversible chronic inflammation. And this is not fully reversible by providing nutrition, but you can stop the decline. You can mitigate the decline, which is caused by sarcopenia during aging. And this is important. So also nutrition matters in sarcopenia patients. And this is taken up by the Asian Working Group of Sarcopenia. They are referring to a growing body of evidence that shows that malnutrition is an underlying cause of sarcopenia, but also a superimposing cause of sarcopenia. And by all means, malnutrition is the starting point for issues pertaining to muscle health. And the nice thing is that they are saying, these experts are saying that nutritional status is modifiable for muscle health issues, and this is including sarcopenia. So also sarcopenia need to be addressed by nutritional therapy. So identifying individuals at risk of malnutrition is a need to provide early intervention, and it's an important public health strategy in Europe, and I think also in Asia, preventing the deterioration of sarcopenia and frailty in the older population. So the Asian Working Group of Sarcopenia is aggregating nicely the important evidence for Asia, and they are pointing to several cross-sectional studies in Asia, making a link between malnutrition and sarcopenia, and they clearly advise for early identification and early nutritional therapy. And they refer to numerous studies which had been done in Singapore, in Taiwan, in Malaysia, and throughout Indonesia, underscoring this notion. So let me conclude on the causes of malnutrition. I told you it's not an easy task. The causes of malnutrition are multifactorial. There are organizational, institutional, and socioeconomic factors, but these factors are treatable and reversible. On the other hand, there are patient-related factors due to disease, due to disability. They are increasing requirements. They may decrease food intake or uptake. And for treatability and reversibility is depending on the degree and the duration of inflammation. But it's approachable. It's very nicely approachable as well by nutrition therapy. And then we have this aging-related factors due to sarcopenia. And here we are dealing actually with an irreversible chronic inflammation, which we call inflammaging. And this is significantly aggravating the above-mentioned factors. So the treatability and reversibility is not that good, but this needs to be approached as well by nutritional therapy, because if there is an overlap of all these three factors, there is a high potential of danger for the patient. So the other mentioned factors, organizational, institutional, socioeconomic, patient-related, must be especially addressed in sarcopenic patients, as they are nicely treatable and as they are reducing the potential danger from being malnourished and acquiring a bad outcome in sarcopenic patients. Okay, so let's move on to clinical consequences of malnutrition. And this is nicely aggregating the evidence for Europe. And I will show you in the end that this is similar in Asia. So in Europe, one consequence of malnutrition is increased mortality. And there is also increased morbidity. We have to deal with increased complications in malnourished patients compared to well-nourished patients. And we are dealing here with infection risk, which is 3 times higher, with increased pressure ulcer rates, with poor wound healing, with post-operative complications, including renal failure, pneumonia, and respiratory failure. And we are dealing here with decreased quality of life. And this is due to an impairment of physical function and a decreased mobility, and the independence is decreased in these patients. And again, high adverse impact is seen in the elderly. So we need to take care of these elderly patients. So these are the clinical consequences. What are the economic consequences of malnutrition? And malnutrition increases the use of healthcare resources. This is important to understand because healthcare resources are meaning we have to deal with increased costs. And if we are talking about malnourished hospital patients, we in Europe have the data that these patients present with increased length of hospital stay, increased readmission rates, and a delay in returning home. And in malnourished community patients, we see increased visits to the family doctors. We see increased hospital admissions and readmissions as well, and the length of hospital stays increased. And if we are looking on costs, and we are looking on different countries here throughout Europe, the numbers for spendings for malnutrition are huge. So they may be differing from country to country, but after all, these numbers are high. I transferred the euros to South Korean won, and you are familiar with your currency. So you see these are high spendings throughout Europe in nearly all countries. And if we extrapolate these figures for all the countries in Europe, we wind up with healthcare costs estimated to 170 billion euro per year. And I again transferred this to South Korean won, which is a huge, huge, huge number of a spending, which could probably at least partly spared if malnutrition would be taken seriously, also in Europe. So in a nutshell, to conclude, malnutrition is associated with increased healthcare resources use and consecutively with higher costs. And you could argue, okay, I don't care about Europe. We are here in Asia. And nicely enough, there is a publication putting together the data for Asia. It's published in 2020, and it's a systematic review looking on 92 studies, including 62,000 patients. And nicely enough, Korea is contributing 17 trials, representing nearly half of the patients evaluated here, more than 30,000. And the results of this systematic review are pretty much the same as in Europe. Prevalence of hospital malnutrition is more than 40%. Malnutrition is associated with an increase in mortality, in clinical complications, in length of hospitalization, in hospital readmissions, and finally, all this is giving rise to increased healthcare costs. So same picture in Asia as in Europe. So let me move on and let me tell you about the benefits we can achieve if we provide oral nutritional supplements in terms of nutritional, functional, and clinical advantages. And of course, there's a range of strategies you can think of to fight malnutrition, but I will focus here on the oral nutrition supplements because they are most important for the community patients and their malnutrition problem. And it's intriguing to me that major nutritional and international reviews point to the fact that ONS is having a significant clinical benefit for malnourished patients when compared to standard care. And I'm mentioning here the National Institute for Health and Clinical Excellence, NICE, of the United Kingdom. And this international or national review board is known for a very critical view on any matter. And so this is an important statement. And this slide is now aggregating all the benefits of oral nutritional supplements, which are multiple and evidence-based. So we have proven nutritional benefit of oral nutrition supplements, increasing total energy and protein intake without decreasing food intake. And this leads to weight gain and prevention of weight loss, especially in malnourished patients. And we have proven functional benefits of ONS, leading to increased activity, better quality of life, and independence measures are improving. Again, in malnourished community patients, these data have been provided. And there are finally proven clinical benefits of ONS in reducing mortality and complication rates. And this, in turn, is reducing length of hospital stay and admission or readmission rates. Again, malnourished patients are presenting with the most severe problems here and the most benefit. So in the following, I have some clinical trials and meta-analyses to prove to you what I was saying in the summary slide. So this randomized controlled trial is providing evidence for greater total energy and protein intake with oral nutritional supplements versus control. And this is important. People said, okay, if we provide ONS, the patients would not eat themselves enough. But this is not the case. Although they got the oral nutritional supplement, they have a greater energy intake than those who are not receiving the oral nutritional supplement. So this is of importance. And this is the basis for this finding. Weight change is positive in older people with protein and energy supplementation. And in this meta-analysis, including 45 clinical trials and more than 3,000 patients, there is significant benefit proven favoring the oral nutrition supplement treatment in the malnourished patient. So imagine 45 clinical trials are here aggregated in this meta-analysis. And moreover, oral nutritional supplements reduce complications and mortality in hospital patients. And this is a meta-analysis of Stratton from the United Kingdom, and they clearly show there's lower complication rate, a reduction by 56% can be achieved with ONS, and lower mortality rates, a reduction of 24%, can be achieved with providing oral nutrition supplements. And there's also evidence showing that we can achieve reduced length of hospital stay if we provide oral nutrition supplements. Again, Stratton showed us an average reduction, which is ranging from 2 days to 33 days, depending on the patient population studied. And finally, there are 2 trials which I'm going to share with you, one from Gabriella and one from Norman. They are showing that specifically if you provide high protein oral nutrition supplements, that you are able to reduce hospital readmission rates by about 30%. And this is an important figure because this is cost sparing. I will show you in the end. So now we are moving on to the economic benefits. And again, this is a systematic review, retrospective cost analysis from ELIA in community studies comparing oral nutrition supplements with control groups. And 13 out of 16 trials showed cost saving, either per subject or in percent of control. So a clear favoring issue here for the ONS group. And if you're looking on countries, France, Germany, Netherlands, UK, studies done in all these countries and many more other European countries, they all show the same: cost saving per patient, cost saving per annum. And importantly, with reduced hospitalization, there is cost savings. And this is shown here by Elia and his meta-analysis. He's looking on 9 RCTs, randomized controlled trials, and he can show here that costs could be reduced with ONS by 16.5%, which is highly significant. So after presenting all these data, I'm now happy to conclude. And I think I could persuade you that malnutrition is a major public health concern. But I hope I only can persuade you and have provided you with enough data that there is a simple answer to the problem. And the simple answer is oral nutrition supplements. They can help to address the malnutrition problem in patients and save valuable hospital resources. So by saving the resources, we can achieve cost savings. So I told you that malnutrition strains these resources. There's increased morbidity, there's increased complication rates with malnutrition. And importantly, I showed you 1 in 4 patients in Europe, if they are hospitalized, they present with malnutrition. And this is increasing hospital stay significantly. And on the other hand, so this strain of resources is costly. And I told you in Europe, 33 million of people are malnourished. And this is costing a fortune, 170 billion euros a year for treating malnutrition issues in Europe. So the answer for you and us in Europe, oral nutrition supplements can have nutritional and functional and clinical benefits. I showed you this in my summary slide and in all the evidence I was providing to you. And by providing these oral nutrition supplements, you can also improve quality of life of these elderly patients, of course. And oral nutritional supplements are cost effective. And for Europe, we could show that overall costs in the hospital care can be reduced by 12%. So let me summarize. The answer is simple. Medical nutrition provides better care in the management of disease-related malnutrition, saving lives and cutting costs. And this brings me to the end. I thank you for your attention and I'm happy to take your questions.